Hi, everyone. Welcome to another episode of Ascend TV. I'm your host, Dr. Leslie Cadet, the founder of Ascend Occupational Medicine Consulting. And at Ascend, we help self-insured employers resolve their work comp claims faster, saving millions of dollars. Today, we're going to do something a little bit different. I'm going to be chatting with one of my teammates, Kim. She is the Director of Claim Analytics at Ascend. She has over 30 years of experience in the work comp industry as a risk manager, a claims adjuster, and she and I are just going to go back and forth and talk about some of the top mistakes doctors make when taking care of your injured employees. And these mistakes are costing your business thousands, tens of thousands, if not millions of dollars. So stay tuned. We hope you enjoy the episode. We think workers' comp is fun. And we get the happiest when a recovering worker actually moves through the system quickly and is able to recover their full life. We find a lot of joy when the recovering worker comes into contact along the way with people who actually care about them and are working tirelessly to get them back to where they can be on full duty and do the types of things that they love with their friends and family. So this topic is very important because it is one of the reasons why a recovering worker can't move through the system. So we're going to start with story time. Kim and I, we like to have story time a lot. And this is a case of a gentleman who had an umbilical hernia repair. He's 49 years old. He was bringing down cases of water when his foot slipped. And then he felt a really strong sensation in his lower abdomen and was discovered to have a 1 centimeter umbilical hernia, no inguinal hernias. So he underwent the repair. There were no complications. And when the general surgeon cleared him approximately 6 weeks later, the primary care provider, the primary treating provider continued the worker's off work status for another month and a half. So I'd like to start by, Kim, as the employer, the insurer, what were you and your team thinking as you were reviewing the clinic notes that were coming back to you?
Well, the first thing, it opens up a red flag. What happened after the surgery? Was there an infection? Lots of questions come, to mind when we are looking at something that doesn't proceed along the path of the average case. In this case, there was no other contributing factors that would cause him to not go back to work timely. So those were the first things that come to mind.
And then could you talk to us a little bit about the costs, and I'm going to throw those up on the screen, associated with this claim?
Yes, so our system, we work very closely with the ODG and the estimated duration of disability guides. That is what we use to help us kind of develop our reserves and come to an understanding of what we believe this claim, the path that we believe this claim to run down. We don't look at the best case scenario and we don't look at the worst case scenario. We try to take each case at its own value with the comparison of what is the zip code that they live in, what is the job that they do, how old are they, and we also connect with the supervisor to find out what their return to work likelihood is. Are they going to accommodate a work restriction, or are they less likely to? So in this particular case, we were looking at setting reserves right around the 9,000 area. We were looking at potentially 35 days for the employee to go from injury all the way through to recovery and a return to work. So when you are estimating and communicating to the injured worker as well as to the supervisor that these are what we are anticipating, and it goes so far left with no real good explanation, such as an infection, it's very difficult to explain.
And so that brings us to the first mistake that providers make, is not even knowing how long an injury or an illness should take to recover from. Now, in most sources like EDD, we were expecting the max to be no more than 51 days, but this case surpassed that by 3 months. And so that's why the claim costs were so high. And I think it's important that when you first see a patient in the clinic and you give the diagnosis, you need to go figure out what is the expected timeline of recovery. And there's a lot of places you can go to get that information, but a hernia repair typically should take no more than 4 to 6 weeks to recover from. And so if you and I, Kim, could go back in time and talk about how should this case have been managed, what are some of the things you would have wanted to see?
I would have wanted to see the individual released to return to some sort of modified duty somewhere around 4 weeks post-surgery. So
Mhm.
I'd like to see him, the employee, to start to get back into the normal scheduling that he had prior to the injury of going to work, seeing his employee coworkers, as well as starting to develop some job strengthening skills,
Mhm.
not to exceed his work restrictions provided by the physician, but starting to at least kind of go back into the normal functioning part of his job.
And I think it's so important to know that timeline because a lot of physicians and providers, when the patient comes to us and they say, well, I'm still in pain, that can be a very challenging conversation to have to say, well, I still want you to go back to work anyway. And so a lot of it is going to be your delivery, and we're going to get into communication later on, but setting the expectation up front,
Yes,
gently encouraging the worker that, yeah, you can do some form of light duty while you're healing, I think is super important. I would have wanted to see the same thing. Once we got that surgically cleared note at week
yes,
6,
right,
we're back on full duty. We want to keep our recommendations in alignment with the specialist, especially when what the specialist is saying is reasonable.
correct.
Okay. We're going to take you all through another case. In this instance, this is a 63-year-old sonographer who was pulling a bed over to her as she was setting up a room to do some imaging, and she felt a pull in her lower back. Now, the case was initially managed conservatively with ibuprofen, Flexeril, 1 round of physical therapy, and work restrictions. Now, within 1 week of that first appointment, the worker was calling back to the clinic complaining of significant back pain with radiculopathy down the left lower extremity that wasn't responding to ibuprofen. She went so far as to go to the emergency room where they gave her gabapentin and oxycodone. I correct that. She had oxycodone from a prior illness. She had gallstones. So she started taking the oxycodone on her own. Eventually, an MRI was ordered that showed multi-level degenerative changes. There was no spinal stenosis. There was no nerve impingement. And over time, she started to complain of pain in her left hip and her left knee. Now, throughout the course of care, the work restrictions were never relaxed, but x-rays were pursued, additional MRIs were pursued. Eventually, the patient was referred to neurosurgery. They were referred to pain management. And when they went to neurosurgery recommended an L4, L5 basivertebral nerve ablation, and a left L3, L4 endoscopic foraminotomy. And those orders or those recommendations were subsequently denied by utilization review. So, Kim, can you talk to us a little bit about what you're seeing on the employer side as this is developing over several months?
Sure. So the biggest thing that stands out in this claim is that the work restrictions never were adjusted. So that doesn't fit within the healing process that any of us go through. If we don't get better, then maybe there is something surgical that we can do to move us into a better spot. But if you file the claim and you never adjust or change your work restriction with no explanation, it doesn't make sense on our end, and we begin to think that maybe the individual is just at a permanent and stationary level because the treatment that you are providing is not assisting them in their recovery. In addition, this individual was, I think, 63.
Yes.
So then, not to be too crude, but there is the mindset of maybe she is looking, maybe she has a secondary gain of staying off work until she gets closer to the Medicare, or yeah, the Medicare age, where she can then, stop working, retire, and start getting medical care under the Medicare. So that's what happens. That's what we think about as an employer, is if the treatment's not getting any better and there's no other outside issue to come along to explain why the treatment isn't working, then we have to look at other areas to see what is it that they're could be trying to gain the employee.
And Kim, could you walk us through the cost of this claim?
Sure. So when we look at the cost of this particular claim, we were looking at setting the reserves, the reserves meaning what we think we're going to pay out on the claim, to be right around $11,000. And you can see here on the slide, it turned out to be a much higher cost claim.
What was striking to me about this case is the way that the MRI showed, very mild degenerative changes, but the solution that was offered from our specialist friends were to go in and do invasive procedures. The PTP in managing this case, in some respects, helped to facilitate that by placing the referral in the first place. And so I know it's really hard when the patient is sitting before you and they keep saying, I'm in pain, I'm in pain, I'm in pain, and you've got a whole slew of other patients that you need to care for. You don't know what else to do. And so the knee-jerk reaction is just to start sending them to all these specialists. And what I found in the workers' comp arena is when we start doing that, it really complicates the claim
It
and
does.
slows everything down. And I'm usually not a fan of utilization review, but in this instance, I was so grateful that the provider over at utilization review denied the request, because it's medically unnecessary and would do nothing more than to further prolong her pain and prolong the length of time that this claim was open. So you're
And it
exactly. Mhm.
and it could be that that's what she wanted. It could be that she wanted to drag out the claim, as I was speaking about previously, as that secondary gain. What can I do to keep myself off of work as long as I can to get myself to retirement and to the Medicare system?
Mhm. So what Kim and I are saying is that the primary mistake in this case is that the work restrictions weren't managed correctly because they stayed exactly the same the entire way through. And so when patients come in with back pain, again, it's important to set expectations, and you want to start with that early programming of, hey, we're going to treat you effectively. You're going to get better. You're going to get back to your normal life. As soon as I start sending them to 10 different specialists, I'm subconsciously sending the message to the patient that, oh, something is drastically wrong with you. You're never going to get better. You're disabled. And that's not the energy that I want to send to the patient. So in this case, I think it would have been more effective that when the imaging came back
Yes.
showing degenerative findings,
Yes.
that you really take the time to explain what that means and really hit hard with the physical therapy. And I know, Kim, at Loma Linda, you all have found great success, if the pain isn't resolved with physical therapy, to go a step further with pain therapy with
Yes.
a pain psychologist to address some of the underlying issues that are generating the pain, because the issue, as our friend Dr. Arya likes to say, is not always in the tissue.
So that is an excellent segue to understanding that pain management typically is managing the pain medication that the employee is on, versus the pain therapy that comes from the brain telling the individual is in pain. So if we can, and it starts really with communication, as you said, Dr. Cadet. If you start with communicating to the patient that you are going to get better, and show that in your lifting of the work restrictions, even if they're very slightly, just continue to lift them and continue to explain to the injured worker that they are probably in pain. I think they were 60 years old.
Yeah, 63.
Yeah, so I'm in my mid-50s and I'm in pain. So it's not unheard of to be in your 60s and wake up every day with pain. And so helping them to understand that the pain is not bad, but managing the pain is what you want to do. And it's not through medication, but it is through the pain therapy that has been so helpful for us.
Yes. And I love what you said about every visit, you're making a slight tweak. So we're not saying on the first visit, you say seated work only. And then on the second visit, you put them back to, 6-hour shifts out of 8. We're saying that every visit, you just inch up that weight restriction. So if you started at 10, maybe the next visit you're at 20.
Right.
Visit after that, maybe you
15,
go to 30
even
and
15.
20. But every visit, you need to be rehashing what the goal is, and that's to get you back to full function. And we're going to do that by each visit challenging you a little bit more so that at the end of the 8-week time period that it should take for a simple strain to recover, the patient is not shell shocked when you're telling them it's time to go back on full duty. You've been having that gradual conversation the whole way through.
Right.
So I love that. I love that. Okay, let's look at another. This is a left anterior cruciate ligament strain. And this is actually a 48-year-old female who said she was helping a patient who wanted the head of their bed elevated. So when the worker unlocked the bed and pulled on it in an attempt to, elevate the head of the bed, her left knee buckled and she felt excruciating pain. She went on to have an MRI that showed this mild ACL sprain without tear. It showed some mild arthritis and some mild swelling around the patella. So over time, she ended up getting a steroid injection with no sustained relief. Her primary treating provider acknowledged that she had a chronic condition, which is the arthritis, that failed to improve. So he started prescribing PRP injections. After that, he started, and those are platelet-rich plasma injections. Then he started giving Synvisc injections. She ended up getting a meniscectomy and a chondroplasty. And at the end of the day, she had improvement in her pain, some tenderness on palpation, and some mild difficulty with walking around. So, Kim, can you talk to us a little bit about what your perspective was as this case was moving forward?
So it tells me that if you look hard enough, you're going to find something to perform surgery on.
Facts.
And from the employer perspective, we're looking at a strain. That's what we cause. We caused a strain. We're looking at setting the reserves around $12,000. And we're looking at an estimated duration of disability to be somewhere around, up to 59 days. So you can tell by the cost of this claim, it went significantly more than that. And there was a lot more investigative type medical treatment done until they found something that they could operate on. So from an employer perspective, I'm not telling you not to, we want that employee healthy. We want them to be returned to work, not only for ourselves, but it is so important to the employee to keep that livelihood of their household, the income that comes in, and the normalcy in their day-to-day activities. So we want both of that, and we can achieve that when we have appropriate communication and appropriate handling of the return to work. So it's, in this particular case, the individual should again have been given work restrictions that were addressed at every visit and progressed along through the completion of the strain.
And the mistake in this instance is the primary treating provider taking on responsibility for something that's not work related. She had osteoarthritis well before the date of injury. And as Kim said, once the strain is treated, Anything remaining is most likely due to her pre-existing arthritis, and she needs to be transitioned back to her PCP. I think it also speaks, Kim, to the importance of having case oversight, because I would imagine that as it was developing and the adjuster is getting the notes and she's seeing the plans for surgery, the adjuster may not have been able to connect the dots that, oh, actually, no, 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 we don't need to do surgery on this arthritis because that doesn't belong to us. So sometimes having someone just kind of peep over the claim and say, hey, we're starting to veer off course, let's come back this way, can be super helpful as well.
Yeah, and I think that sometimes the physicians hear a lot from the Workers' Comp Appeals Board judges that you buy it, that if you begin to treat it, you buy it. If you aggravated it, you buy it. That's only true in the sense of you have to get them back to the pre-injury capacity. So they seem to forget that, yes, you may buy whatever it is that you've purchased in that body part by treating it, but we're not going to heal that body part. We're going to bring them back to a pre-injury capacity. So
Mhm.
that's, and then you can address apportionment that way. So it is important to have a physician that understands this is a strain. We're going to treat you for the strain because you don't have surgery on strains. And you'll note in this case, there was surgery done.
Was.
So, tell us what we are responsible for. Let's get them the best health care that we can to get them back to their pre-injury status. And then the rest can be deferred to their primary care physician outside of the work comp claim. And it's just a matter of explaining different payers. Workers' comp is the payer for this. Your healthcare provider is the payer for the arthritis.
That's exactly right. And, ACOM on their website, they have a really good article about work relatedness. So, for any providers and physicians watching this who struggle in that area, I would encourage you to go and read that article as well to help give you a framework for determining what's work related and what is not. So I think we both agree that if we were handling this case, it would have been diverting her to her PCP once the strain was taken care of. And we can also benefit from collaborating with other providers, right? And like having a conversation with the treating providers to say, hey, this is what we're seeing. What are you guys thinking?
Yes.
Okay, so we've got another case for you all. This is a 27-year-old female. She's actually a patient care assistant, and she was evaluated for a left wrist injury. So she was sitting with a patient who was on watch for suicidal ideations, and somehow bed cords were left on the patient's bed. So the patient grabbed the cords, tried to wrap them around their neck, and the worker called the nurse. The nurse runs in, attempts to remove the cords from the patient. And so, as this is happening, a struggle ensues, and the patient grabs the worker's wrist and forcefully twists it and hyperextends it backwards. So, within 30 minutes, the worker said her wrist started to swell and the pain continued to get worse. So initially, she was managed conservatively with ibuprofen, a Toradol injection, physical therapy. Work restrictions were given, saying no use of the left hand. And this case evolved over a 5-month period. And during that period, an MRI was within normal limits. A nerve conduction study was within normal limits, but the worker continued to say her pain was unchanged. So she was eventually referred to orthopedics, who gave a steroid injection for a diagnosis of De-Quervain veins. And ultimately, her care was transferred to a different provider due to interpersonal differences. The worker did not complete her occupational therapy. She didn't do her modified work assignment. She was referred to a pain therapy workshop but did not attend, and then requested the disability paperwork be completed on her behalf. So, Kim, what are you all thinking as the employer?
So I'm thinking that the pain therapist should have been assigned much sooner in the case. When you're talking about an individual who is young and involved in a stressful situation that she was involved in, that pain therapy specialist should have been assigned by the second visit, when they realized that her pain threshold was not didn't correlate with the strain
Mhm,
diagnosis. And
mhm,
so in this case, from not just from an employer perspective, but from a person perspective, it tugs on my heartstrings because of the fact that we have a very young employee who witnessed and was a part of a very stressful situation. Even though she wasn't alleging stress from the event, you can see through the treatment of her pain not getting better, the fact that she didn't go back to the modified duty assignment, something else is brewing. And so had that pain therapist been assigned sooner, I think that we would have, and that she participated in it, I think we would have seen a much different outcome.
a much different outcome. And then if we can talk a little bit about the costs on this claim, because
Sure.
it's been on for so long.
Right. So with this case and a young employee, just with the wrist strain outside of the psychological issues that took place, we were looking at, a $12,000 reserve. We're looking at having her back to work at right around the 45th day. So full duties right around the 45th day for a strain type of injury. This case went on to cost us just double what we were anticipating. And it's still worse because of the fact that that psychological um, injury has never really been dealt with.
Mhm. So that brings us to, mistake number 4 is poor communication techniques. I think that there's a skill and an art of being able to walk into the exam room and read the room. So even though the patient, as you said, is not claiming stress,
Mhm.
most people who are part of an attempted suicide and trying to stop it, that is extremely stressful. So for us as providers to not even address that component of it, and we just hone into the body part, that's a mistake. You've got to look at the whole person. There's an impact to not listening. So ultimately, this worker transferred her care, right? Because people aren't listening to me. So I'm not able to establish trust. My provider is not asking the right questions, right? So there's no building of rapport. My provider's not explaining things to me. So again, there's no respect, there's no trust, there's no rapport. And these things impact the claim. So when the worker then requests a new provider, the new provider just can't go in and close the claim. You're ultimately starting all over again because now the second provider has to build the trust, build the rapport, build the respect, get united on what the goals are, and start doing some of the things that should have been done from the beginning, which is get her over to pain therapy so we
Right.
can dissect.
Right. And at 5 months, something that could have been maybe a one or two telephonic discussion with a pain therapist, after 5 months, and I'm not a physician by any means. However, you are looking at a little bit longer PTSD type of situation because it wasn't addressed correctly at the beginning. Now, as a hospital, um, we do offer EAP programs and
Yes.
de-escalation programs. And so
Yeah.
that would have taken place in this case. But when you're looking at someone so young, she probably herself didn't know how to process it.
True.
And it got addressed, I think you said at 5 months. Well, at 5 months, she's buried that
Right.
psychologically. She's trying to
Right.
move on, and she has now interpreted it as pain, and a pain that's not going to go away.
Mm-hmm. Mm-hmm. So, in this instance, these are things that we want to be mindful of, not just honing in on the body part, but really taking a step back and looking at the entire case for what it is and taking care of the little things that are going to derail it and end up costing the employer more than double what it should have.
And potentially taking an employee completely out of the workplace for a very long time or permanently.
That is correct. Studies have shown that if a worker has been out of work for 3 months, or more, the chances that they will ever go back to work drop by 50%. So those first 12 weeks are really critical in the way that we're managing the return to work process.
I agree. And I think to your point of treating the whole person, you do in workers' comp for years, it's been a very regiment of don't mention sight, don't mention any other body part, don't mention high blood pressure. We're not going to address that in workers' comp, but it never worked really well for us. So I think now if we look at the employee as a whole person, we can provide some type of treatment. Maybe we don't, again, to the issue of the arthritic condition, we're not going to cure the arthritis. We're going to treat the strain, and then we're going to help them funnel them back into the primary care physician to treat and continue to treat the arthritis.
Yeah.
So as well as the high blood pressure. If we have somebody who has high blood pressure and we need to have surgery and they can't have surgery because it's not because their blood pressure is not under control, let's make sure that they can get that blood pressure under control through their primary care doctor so that we can proceed with surgery and move them along through their care.
And so often there's this rigid wall up between the work comp provider and the primary care physician, which shouldn't be there. Again, I guess I'm different, but I pick up the phone. I say to the patient, "Hey, do you mind if I talk to your doctor?" Because I know that a lot of what I'm saying, the patient may not be able to fully grasp, and the message may get lost in translation. And I will reach out to the PCP, whether it's an email or a phone call or whatever, and just say, "Hey, from a work comp perspective, this is what I'm seeing, this is what I'm doing, this is how you could help this worker get better faster." And I found all the PCPs I've reached out to have been very collaborative in that way, but it does require an extra step. It does require extra time. And I know a lot of us are saying we don't have time for any of that, but it would help and go a long way if we would break down that barrier to communication with the PCP.
That's an excellent point.
We hope you enjoyed that episode. And if your organization is in need of help with their workers' compensation program, please reach out to us. The link to connect is in the show notes. If you have not already liked, subscribed, and shared this channel with other self-insured employers that you know, please do so today. Until next time, peace.